Everyone, myself Dr Nisha Malik, Assistant Professor from Department of Physiotherapy, RPIIT Karnal. Welcome to our YouTube channel, which is RPIIT Academics. So this video is continuation of amputation. In this video, we're gonna talk about principle of techniques. So for thigh, flaps are equal and scar falls just behind bone or long anterior flaps is used so that scar will be well above the bone end. For end-bearing stumps at distal end of femur, long anterior and short posterior flaps are used. For below knee, if circulation is adequate, anterior and posterior flaps of equal length allow the scar to lie transversely, immediately behind the tibia but in ischemic limb. A more vascular posterior flap should be longer and scar lies anterior, well above bone end. In schemes, long posterior and short anterior flaps are used. Base of posterior flap should be more posterior medial for better vascular supply. So for muscles divided just distal to level of bone section, with muscle retracting to so line. Stabilization of stump by fixation of muscles to bone means myodesis, or or bringing muscle over the end of bone and fixing it to the opposing muscles. Myoplasty under proper tension improve control of stump. This also lessen phantom sensation and painful contraction during stance and gait. Myodesis is contraindicated in PVD. Bulky muscle mass should not be placed bone end. Instead, muscle is first relieved and contoured before placing it above bone and to obtain a properly shaped cylindrical stump. So in nerves, isolated pull down gently, section and allowed to retract above the sirloin. Strong tugging at a nerve predisposes to neuroma and phantom limb pain. Injection closer or burying the nerve in bone should be avoided. Large nerves are ligated before division. Then blood vessels. Major blood vessels are doubly ligated with chromic catgut or non-absorbable sutures. Minor BV blood vessel are simply ligated. Then the tourniquet is released and hemostasis completed.